once people said, okay, how about, if this area is okay, then we should. So many people are now having a small booty like mine, and
small,
I
yeah,
also
maybe.
had 9.5.
Yeah. Now that is true here as well. They said if you have something very small here or here, it's okay. I just shaved everything. That's all right.
Amjad, do you want to introduce Danny and we can start then? Amjad, you're frozen. I think it's dull and wet, and the Wi-Fi doesn't work. So that's not a good scenario for Coventry.
Yeah.
Okay, I think I'll just introduce you. I think Danny, nobody needs to introduce Danny. He's done some amazing work with the Amin Kassam's team, and since then has taken just his own way and has done brilliant work. And what they have done over the years is really a role model for everybody else. So I think I'd request Danny to start. And today we are talking about pituitary tumors, and hopefully we'll learn loads from Danny. Thanks, Danny.
Thanks so much. I see that he's not frozen anymore. Amjad, or maybe he is again.
It's frozen again, so we see him in different images.
Okay, we'll start then. I guess we can talk more about everything at the end. So I have a question just before I start, like for how long should be my talk? I forgot to ask that before.
How long do you want to talk?
Well, no, I can make it
no, you're the only speaker today. Okay. You're the only speaker today. So, you speak as long as you want, and then we have lots of discussions. And, we can, in every 5 minutes, maybe you can stop and ask questions. Now we can hear you, yes. So every 5 minutes you can stop and ask questions, and people can raise their hands, and we can unfreeze their mic, and they can even talk.
Okay, that sounds
Amjad,
good.
is that okay? Can we start?
Yeah, I think we can start. Okay. And in the end, you want me to show 4 or 5 cases? Just simple quiz?
That sounds good. Then we can discuss.
Yeah. Okay, brilliant.
Okay.
Okay, so I'm going to go ahead and share my screen here. Should be able to see that now.
Yep.
Yeah, so once again, thank you so much for the invitation. It's an honor to be here sharing some of our experience. And today our decision is to go with probably the most common, I don't like to say simple or easy, but it's definitely the most common pathology that we do in skull-based, particularly when we're talking about endonasal, endoscopic, and transsphenoidal surgery. So definitely the treatment of pituitary tumor. So there's some nuances that I like to share, and some of our philosophy that I think it is, hopefully you guys enjoy, and please feel free to raise your hand, and we'll go over any detail, to clarify any aspect. But that's the idea. So anytime we are facing a situation like this with a pituitary tumor, there's some of the things that there is in our mind, and particularly when to indicate surgery, like what is important when we indicate surgery. So the most common in neurosurgery is definitely to relieve mass effect. So anytime there is mass effect on the optic nerves, particularly the most common symptom being bitemporal hemianopsia, but sometimes we see also compression of the cavernous sinus and other problems like that. So that's probably the most common and typical indication for pituitary surgery, to take a mass effect away from the neurovascular structures. The other is to normalize hypersecretion. So that's we see basically more commonly in Cushing's and acromegalics, but also sometimes it's important to perform surgery also in prolactinomas, and particularly when there is like side effect with the medication, or one of those rare situations where the medication dopamine agonist doesn't work. And sometimes something that we discuss is there's probably a percentage of patients with a very small pituitary adenoma with a prolactinoma that can benefit from surgery by just going one procedure, get it cured, and particularly the ones that are not invasive, but that's kind of something that is still controversial. Definitely we do the surgeries preserving the gland and with the goal of mainly, avoid any complication on the pituitary gland. Mainly, the main one we are always worried is diabetes insipidus. So being very careful with the gland and the posterior gland is very important. And we want to do a complete resection, remove as much as possible to avoid recurrence. That's kind of one of the issues with this surgery, is to leave a little behind. If it is a functional tumor, is very evident right away in terms of the surgery not being very effective. But even for the non-functional adenomas, over the years, they tend to come back. So we want to make sure you remove everything as much as possible, and hopefully everything. And of course, we send this tissue to pathology for diagnosis and analysis and scientific studies in future, helping people in the future. So just to have an idea in terms of our practice, this is when in one point, we look at 225 patients that we have done surgery. And just to see in terms of proportion, it's most of the patients we take care have tumors from 1 to 4 centimeters. You will see that around 13% have microadenomas. Those are the function adenomas. The majority, the indications is related to mass effect. And 4% of our cases, are the ones that we can call giant. I'm sure in Pakistan, and this is much bigger percentage there. I don't know if you want to raise your hand and talk about that. But definitely, I think our practice, shows 4%. And I don't know if you want to say more or less the percentage there in Pakistan, Salman.
It's for our cases, they're about 40%, which are giant.
Yeah, so 10 times more kind of proportionally. Yeah, I understand that, because I think the system and the number of people that basically just go to seek health help and see a doctor when they are going blind, and they already went blind in one eye for so many years, and is different than what we see here. But that's we still see around 4% of the giant. So as you can see here, 2/3 of our patients have the supercell extinction. So that goes exactly with these cases from 1 to 4 centimeters, which 3 centimeters is still large, and we have a good amount of those patients. It's very, very rare in US to see a patient that already lost completely function in one eye, for instance, and then wait until the other eye is affected. But interestingly, I have a case like that this Friday coming up. Patient that went blind 5 years ago, and she actually went to the ophthalmologist, and they thought was just a stroke on the nerve, did not do any imaging, and now she started losing function on the other eye, did an MRI, and she has a giant tumor there. So we're going to take care of her on Friday. But 2/3 of our cases still like with the suprasellar extension. The majority of our cases represent non-functioning adenomas. And as you see here, like around 15% are the ones that have some staining for gonadotropins there, and 15% is like Cushing's cases in our series. Interestingly, in terms of resection, when there's no invasion of the cavernous sinus, we basically adjust that total resection to almost 96% of the cases. So it is the main limitation for complete resection of pituitary adenomas, in my opinion, is really paracellular invasion. We do enter there, as you're going to see in some of my examples, like we go aggressively in the cavernous sinus, but in general, I don't consider those like gross total resection. Even if the MRI looks great, I know that there's a good chance on the other side of the carotid artery, you will have some residual, and this either will grow back, or if it is a functional tumor, you will still see signs of production of hormones. In our series, this specific cohort that we have here, we had 2.2% of CSF leak, and then I'm not going to go into detail here, but most of the reconstructions that we do these days is with collagen matrix and the use of mucoperiosteal graft. And then very rarely I use fat or flap these days actually for reconstruction on pituitary surgery. So around 2.2% as you know, I'm not going to go into detail of this, but the technique we do, 4 hands, 2 surgeons. I always do surgery with the ENT, as you know. I have Dr. Brad Otto and Dr. Ricardo Corral. They work with me, and we do all this. We were talking very briefly about what, in terms of the COVID-19, I think is something that people are curious. And just to mention again, I think we don't know what is right and wrong these days with COVID-19. What we've been doing here for the cases that are urgent and need to be done, we are doing 2 weeks of quarantine. We're testing every patient 2 days before surgery, and everybody in the room uses a mask, and there is a recommendation to also use the shield, and N95 mask is everybody uses. And this is interesting because it has been changing over these last few weeks. Initially, we didn't have mask enough for even for anesthesia, and now any intubation across the university here, they do with the N95. Initially, there was a concern if we will have available for everybody, and now they are re-sterilizing the N95, so that has been helpful. But this is the way we've still been doing. We're trying to avoid or use the less as possible the drill in these cases, and during COVID-19 outbreak now. And this is kind of like the way we do 2 hands, try to get the ENT on top, and the neurosurgeon can use in the lower part of the nose, and for the resection of these tumors. Here's a picture that we published when we use the Qtip. I like to use the Qtip. It's very cheap. I'm sure you can have that in Pakistan with a low cost. So it's a great retractor. It's probably the most common thing I use in pituitary surgery for retraction. And again, it's not an expensive tool. I have an interesting story about that, because when I published about the Qtip, when the reviewers sent for review the paper, they were like, well, no, I don't think this is very relevant. And I answered back saying, you know, listen, it may not be very relevant for here, but places like around the world, like where I'm from, Brazil and Pakistan, you know, it's very important to have cheap instruments in your arsenal and very effective. So that's one of the ways kind of I pushed the paper through, and they eventually you know, accepted, and we got published there. So initially in our series, kind of 10 years ago, we used to do flaps for every pituitary adenoma, particularly when I was in Pittsburgh. We were doing flaps for everything. And I changed, has been 10 years, I'm Ohio State. I started to change by doing what we call rescue flap for during the approach for tumors located in the cell as small pituitary adenomas. And then we will do flaps for the large ones, thinking, you know, more likely we'll have a leak. So we will elevate the nasoseptal flap for the large ones, and we will just preserve potential pedicles for flaps for the smaller ones. But then very quickly, probably around 8 years ago, we noticed that even for the large ones, if you still have a low percentage of CSF leak during surgery. And I calculate, we look at my own numbers, it's around 15% of the time I would have a leakage of fluid during surgery. And then so we start doing rescue flaps for every case. So basically we do some of the incisions. I'm gonna show it to you how it looks like. It looks like this. We do the incisions in the roof of choana. We preserve the pedicle of these cases, and so we can work above and below this pedicle. We don't do the whole flap, and that's what we call rescue flap, is because if you do have a CSF leak during the case, then you can still go back and elevate the flap. Initially, when people were doing endoscopic endonasal cases, they would coagulate this portion of the mucosa because, you know, with the fear of epistaxis later on. But the reality is that by preserving this, you have still the possibilities of go back and do your nasoseptal flap if necessary. So this is what we've been doing for every pituitary adenoma, with the exception of a case that I know the tumor has spread into the subarachnoid space, and I'm planning to go there and chase that tumor. If I'm planning to chase that, then I would actually do a flap, which is very rare. Most of the tumors they are still under the diaphragm macella and allow us to just do the rescue flaps. So here's using the microdebrider. My ENT partners, they like that a lot. And what is important in this case is really to expose all the way around here. So you see here, I'm drilling the rostrum of the sphenoid to expose the lower aspect of the sella. And then we want to have a full exposure and drill this upper part of the clivus here to really see all the way around. So I think that's one of the tips, very important. I think if you leave bone laterally or superiorly or inferiorly here, you end up not having a good exposure, and you end up maybe compromising your resection as well. You don't want to be restricted on the lateral walls inferiorly or superiorly. So the inferiorly, something I learned from John Jane Jr. back in the day, is that you want to make sure you can put a suction under the pituitary area there. And superiorly, you want to see the plenum. And for these large ones, I like to remove the posterior part of the tuberculum sella. Here, even exposing some of the optic canal area for the large ones, particularly those that have a second bubble. You know, if you get some of those patients that they have like a snowman going up, so removing this bone here, something I learned from Amin Kassam, very important trick. And the reason is because if you don't remove the bone, it's difficult to access the upper part. What happens is, if you leave the bone here, when you put your instruments, it limits your movement of instruments there. And if you remove the bone, you don't need to open that dura, but you actually can retract that dura. And with an angle scope, you can look much higher, even to some extension of the tumor to the anterior skull base. So some of the other aspects that I think are very important is to very early in the case, identify the pituitary gland. So here's the we open the dura and we open with the knife, then you got a little stravization, a very soft tumor. And this is the way we talk about doing extracapsular resections. Here with my Angelina dissector here, I'm exposing and defining that interface between the gland and the tumor very early in the case. I think that's very important to optimize your resection and preservation of the gland. Of course, preservation of the gland makes sense, but in terms of optimizing your resection is because by finding that plane, you actually find the limit of the tumor. Of course, if there's tumor invasion on the cavernous sinus, you cannot limit and find that all the way into the cavernous sinus, but the side where you have pituitary gland, I like to separate that. Then you go take the tumor, and then you go back to this plane. And once you go back to this plane, then you can actually make sure that you get the whole tumor out. So very early in the case, before taking tumor out, I'm already looking for the gland. And that's something I recommend everybody to practice this, and because it's very easy to put this incision and then just put a curette. I've seen many surgeons doing that, and you just curette, but then there's a high chance you end up leaving disease attached to the gland and the corners there. So here's the way we do. We then dissect, decompress, and then go back to that plane. For the functional tumors, it's important to remember that when you're trying to do extracapsular resection, there's always a layer of pituitary gland in front of the tumor. So you have to define the position of the tumor. As you can see here, you see gland on the left side. This is an old video, but I like it because, you know, we put that incision right at the interface, and then the tumor is still encapsulated with the pseudocapsule, which is made of normal cells of pituitary gland. And then we can separate what's the pseudocapsule with tumor from the right side here and the normal gland on the left. Once you define the tumor, it's okay to actually rupture the capsule. Some people spend like 10 hours taking the tumor out to be able to take completely extracapsularly. I think if it comes completely extracapsularly, it's great. But if it ruptures, like this case, because you defined this plane earlier, you can actually go back and continue that plane in the residual tumor that you see in the back of the cavity there. So even if it ruptures like that, you go back, you recapture, and you re-find that plane and take the whole tumor out. So tumors like this, when we do extracapsular, you can see that it's, again, very important to do an incision on the normal gland to be able to get this type of result where you have basically a complete resection of the tumor. This is a MRI done 24 hours later. You can see where the tumor was. And then if you repeat this MRI more than a year later, it's almost like you were never there. You see a little scar where the tumor was, and that's it's great for follow-up. I avoid putting fat on the sella because I think that's it's very helpful not to have any fat, avoid scar there. I use collagen matrix inside the cavity. I think that works much better. So in general, of course, like I said, we're trying to avoid the drill now, but in general, my practice, I use a lot the drill to make it very thin, the sella. Recently, I talked to friends from China. They said they are back to normal, back to drilling, and not much worried over there with COVID-19. So I'm looking forward to be in the same scenario. Very careful. I like to open the dura. And then here I'm already opening the gland, as you can see here. I put a little cut in the gland. I found the gland. The other thing I think is important when you open the dura, be careful not to open too high, because often after you take the gland, the pituitary tumor out, the gland collapses away from the dura and you end up with a CSF leak between the dura and the gland. This is an example that I actually found the plane earlier, took part of the tumor, and then I went back and resect the rest of the tumor. You can see the posterior pituitary gland back there. And then I do the reconstruction with a collagen matrix like this. And I also like to use, if we remove the middle turbinate, I like to put the mucoperiosteal graft on top of the sella with the collagen matrix in the cavity. Or if we were able to preserve the mucosa of the sphenoid, we rotate the mucosa of the sphenoid back to cover the skull base defect. So like here, I'm kind of moving that mucosa away. And if possible, at the end, I rotate it back. If not, then we use the turbinate mucosa. If we preserve the mucosa of the turbinate, we've had some situations where we got a little bit of mucoperiosteum from the floor of the nose in order to cover that the defect of the skull base there. So this is another example here where we are opening the dura carefully and then finding the gland. See, very carefully, I'm moving the gland away and defining a 360 exposure of the gland of the tumor. So basically, we'll find an interface between pituitary gland and pituitary tumor there. Here it's almost like a episiotomy, kind of to be able to do a delivery of this tumor. And here's an example that I try to continue there, but very often I see that the tumor is too bulgy and it kind of progressively comes down. And then it's okay to basically cut in half or debulk the center. But this was an example that we were able actually to go around it and posteriorly. And you can see here that the tumor has less vascularization compared to the normal pituitary gland. And here we were able to then go all the way around, put a very mild retraction there and get that total resection and resection of that tumor out of there. So here, then we go back and you can see the pituitary gland going back in place, the cavernous sinus is going back there, and then the final inspection for resection. The other thing that we've been using, and it's not extremely helpful, but it's always one more information, is ICG. This is ICG green, and the pituitary gland enhances very well, as you can see in an MRI, and the tumor enhances less. So it's not as useful in the beginning of the case, perhaps for some situations like this, but it's been somewhat helpful at the end of the case when you don't know if it is still pituitary adenoma or pituitary gland. So you can run another pass of ICG, and then you can, at the end of the case here, so when you have a cavity, sometimes there is a piece like, is this gland or is more tumor? Instead of go aggressively, you can run ICG again, and then if you don't see any enhance, then it's not the gland. But the gland still enhancing at the end of the case shows that you preserve the blood supply for that gland, and you can see the cavity. So again, because the tumor doesn't enhance with the ICG and the cavity that is clean also doesn't enhance, is not a major advantage. It would be great if it was the opposite, right? So if you could have enhancement on the residual tumor, but in this situation, the ICG helps to position the carotid arteries, as you can see here, and helps to define the healthy pituitary gland at the end of the case as well, and to differentiate some of the gland and tumor throughout the case. And here the reconstruction with collagen matrix, and then the final reconstruction here. This is the mucoperiosteal graft that in this case we remove the middle turbinate, and that's something I always leave to the my ENT partner to make a decision in terms of space needed for access, and that's the way we do the reconstruction with a mucoperiosteal graft, and here we're putting some of the nasal pore at the end. So a little bigger tumors is still, you can go around and do extracapsular resection. Again, see, look at here. In this case, I opened the dura like a U, and as I rotate it up, there is gland here. So this is tumor and this is gland. So by doing that maneuver, we're able to land directly in the plane of gland and tumor. And then in this case was quite large, so I went ahead and performed a decompression of the pituitary adenoma by sampling the center. I sent this for permanent analysis. I stopped sending pieces of tumor for frozen section because you know what it is, and unlikely to be anything else. It just increased the price of care for the patient. So in these cases, we debulk the center, make it less tense. And then with the Qtip here, you can see how we use, helps me to rotate a little bit, and then I can actually move that capsule of the tumor away from the pituitary gland. And once again, you can see vessels on the paper-thin pituitary gland over there and no vessels on the adenoma. So you can really see that plane well. And it was just right from the opening of the exposure that allow us to land in that plane between the gland and the tumor. Very important not to go extra gland. I've seen some very, famous neurosurgeons actually start thinking that they're going extracapsular, and they go extra gland, and they end up with a view of the third ventricle at the end. It's not necessary. Very important to identify a little bit of gland on the diaphragm there, and here's gland coming with the tumor. So instead of just pulling out, we came back with the scissors there, put a little cut, avoid a leakage, preserve the gland. And this is a complete resection, extracapsular of a tumor. There's a little firmer. So when it's firmer, it's actually easier to do it compared to when it's very soft. But again, very soft ones, still I recommend for you to insist with that plane. This is the post-op. Then a tumor like this, when we look at carefully, is a question if it is invading the cavernous sinus, but as most of you know, most of these tumors, they push the wall of the cavernous sinus and don't really invade. We always look where is the pituitary gland before surgery, and in this case, you see forming a dome around the tumor. And here we do the same technique. I debulk the tumor internally, and I try to go around. So here's, for these larger cases, we end up using the Doppler to define the position of the carotid arteries. And here I'm gonna advance. You see here, as I open the dura, I'm looking for that pituitary gland. And here, when I debulked, very thick tumor still here on the patient's left side, and we're debulking resection. But important was really to encounter the gland and around it. And here's what I'm using the curette as a dissector. You see there's a layer of gland, and I dissected that layer of gland and I move it up. So now the gland is sitting right here. Once the sitting right there, then I continue using the curette as a dissector. So I don't like to use a curette blindly. I always looking at the plane, and I like the shapes and that the curette has, allows us to really go deep and far away. And here I'm using as a dissector, and this is the diaphragm that came down in this case. And you get this type of beautiful resection with the gland sitting on top. And now I'd like to talk about one more aspect that we noticed over the years here. Look at my own numbers, and I noticed that for the large tumors, that everything went very well. Those are the ones having diabetes insipidus after surgery. And we got statistically significant the fact that the tumor being large gave us a more incidence of diabetes insipidus, even for transient, for permanent. So what we've been doing over time in a case like this is an old imaging. What I've tried to do at the end of the case, I actually fill the cavity with a Duragene, collagen matrix, a gel foam, to keep this pituitary gland deep and closer to the hypothalamus. I think the theory that I actually heard this first time from Don Kelly out of Santa Monica is that he was always afraid that the diaphragm coming down actually stretches that stalk. And I start paying attention since he mentioned that to me, and that was a very important tip, because after this paper, we actually start really like putting, keeping the diaphragm superiorly, and that allowed us to decrease the incidence of diabetes insipidus. We're trying to look into that data now for future publications, but I really recommend don't leave that diaphragm coming into the sphenoid sinus. Put like at least gel foam to push back in and keep some pressure there, so the pituitary gland stays closer as it was before you did the surgery, closer to the hypothalamus. Okay, so now we will move here to another part, which is situations where we actually open the subarachnoid space to get the tumor out. So the idea in a tumor like this, as you can see here, spilling into the anterior fossa, you see that. This is a tumor that when I trained many years ago, we will actually plan a craniotomy for these tumors, because even with that concept that if you go through the sella and you remove most of it, it's going to descend. If it's already in the anterior skull base, it's not going to descend. So those are cases that historically we would do craniotomy to resect because of this projection in the anterior skull base, as you can see. So these are cases that now for the last multiple years, we plan on a expanded endonasal approach, opening the subarachnoid space. Again, these are rare situations. The sella is down here. We cleaned the sella already, and now we're moving the tumor down. And you can see the dorsal aspect of the pituitary gland with the vessels, the optic nerves, the anterior circulation. You can see here a branch of the anterior circulation going into the pituitary gland. And here you can see a plane where the tumor that was coming to the anterior skull base and the gland there. So in this situation here, we cut right at that plane and basically complete resection, avoiding a craniotomy for this patient. As you can see here, we basically cut, and then we were able to get a complete resection. And in this case, of course, we do a flap. So again, if you're planning to go to the subarachnoid space, like in this situation, then we do a flap of the sinonasal cavity, prepare, and then we will put Duragene into this cavity, and then we will cover it up with the nasoseptal flap afterwards. So these are the examples. So the flap was used for reconstruction here. The gland is preserved there. And this patient, for instance, had normal gland function afterwards and no leakage of fluid. So, but when you do this, you're definitely increasing the chance of complication, particularly CSF leak afterwards. Here's another example of a tumor spilling into the anterior skull base. We did the same technique, open the planus sphenoidale and get it out of there here with a flap. So for these, again, we use the flap for reconstruction. So there's some other situations, pituitary tumors, as they are more invasive. These are cases that can invade the cavernous sinus. And these are examples of pre-op and post-op when we went to both sides of cavernous sinus. Here's a situation that another advice that I like to give. If you see a tumor like the one I showed before with cavernous sinus, but no suprasellar extension, that doesn't make much difference. But when you see suprasellar extension and cavernous sinus invasion, my recommendation is for you to remove the tumor from the sella and then go into the cavernous sinus before going to suprasellar. We have a tendency to, as neurosurgeons, let's take care of the vision loss first and decompress the optic nerve. The problem with that is that you end up with a too early of a herniation of the diaphragma cell down. And unless you have a lumbar puncture and drain some CSF, but if you don't do like that, because I don't usually do, then that diaphragm may become in front of you and prevent you to free good visualization of the cavernous sinus on the left. The other thing that we do when going to the cavernous sinus is a transpterygoid approach. So here we are removing the posterior wall of the maxilla, and removing some of that posterior bone, exposing the pterygopalatine fossa. See, the sella is more in the middle here. These will really push down lateral to the left side. So this is something we learned from the Bologna group, you know, with Dr. Giorgio Frank and Pasquini and Mazzatenta. They aggressively do a transpterygoid for this exposure of the cavernous sinus, and we've been doing the same. And it's very helpful here, even following the video nerve and so on. We use the Doppler, identify the position of the carotid. And then here, just to make it faster, we open the sella first. Here you see the tumor coming from the sella. We will debulk the sella, but not all the way up, not all the way up. So this was a very soft tumor. I like to use two-hand suction technique, like I learned from Dr. Kassam. And then I go to the cavernous sinus. So see, I'm leaving some tumor superiorly there. And now I'm gonna move my attention to the cavernous sinus. And then the way we do here for the cavernous sinus, I use a ball probe, a dissector, and I go all the way in front of the carotid. I use the Doppler. And here with the transpterygoid approach allows you to really go lateral, and I'm cutting the periosteum of the face of the cavernous sinus. Expose all the way lateral. And now I'm lateral to the medial wall of the cavernous sinus. You can see the wall is right there. We usually remove that wall as well. But I like to kind of go on the other side first and start exploring. And here's a suckable tumor. So these are examples of cases that you can end up with a very beautiful resection. The MRI looks gorgeous afterwards because you go in front of the carotid, behind the carotid, you go to all compartments of the cavernous sinus, posterior and anterior to the siphon. And then here I remove the medial wall of the cavernous sinus completely because this was a patient that had Cushing's disease. Now I'm using the Qtip and going to the suprasellar component. So that's the sequence, and you can see now the herniation of that diaphragm coming down, opening the last corner there near the right apex of the sella to then make sure with the Qtip, I like to push the diaphragm of the Qtip, because if you use a suction, you may perforate. So this, I think, is a very important way here to really get to that gutter and get the last piece of tumor that may be in the corner superiorly. I went back to the cavernous sinus and to double check, and then we're done here with a resection. Put some flow seal everywhere, like it can be spongostan or Surgiflow, but hemostatic agents. And I like to put a piece of collagen matrix inside the cavernous sinus to protect the carotid, and I put another one in front of the herniated diaphragma sella. There's no CSF leak in this case, but I put this to reinforce. In my own numbers, I noticed that when I do that, less likely to have a leakage after surgery. I had some cases that did not have a leakage of CSF during surgery, but it ended up happening afterwards. So I like to do this. As you can see, I'm pushing material, gel form inside the sella to push the diaphragm superiorly. And this is the postoperative MRI with decompression of the optic nerve. The patient got completely vision back to normal. And you can see here, the cavernous sinus nicely explored. I never say that these patients get cured, particularly if it's a functional pituitary adenoma, but you can get very good resections on the cavernous sinus. This is another example. Very common to see recurrent tumors recurring mainly coming from the cavernous sinus, because this is a patient that more than 10 years before me, a good neurosurgeon had removed the tumor, but left some disease in the cavernous sinus, and from the cavernous sinus recurred to form an invasion of the cavernous sinus and suprasellar. And these are examples that, like I said, we would clean the sella first, go to the cavernous sinus, and then resect the tumor. So here, I would just show you the importance of the Doppler again into finding the carotid, a transpterygoid on the right side on this case. Here we open in the sella. The sella showed the tumor was suckable, but look at how medial is that cavernous sinus wall. So because I Doppler before putting this incision, I removed the medial wall of the cavernous sinus, and now it's purely cavernous sinus surgery when we do that. And now we're progressing into the cavernous sinus using angle scopes, angle suctions. And you can see here as we advance in the resection, using angle suctions there, here you will see the carotid artery that we get exposed. The very white there is the carotid artery there. So you can even go lateral to the carotid artery. You can open the the dura a little more, and no leakage here. And we do the reconstruction like I described with the collagen matrix, and no need a nasal septal flap. I think if you cover the carotid well inside the cavernous sinus with the collagen matrix, you can then use a mucoperiosteal graft and cover it up like, and this is the post-op MRI. Sometimes you see small tumors in the cavernous sinus. I think those are the more challenge. If you have a large tumor, it creates space for you. You can actually follow the tumor. It's easy, at least straightforward. When you have a patient like this is a patient like Cushing's disease and 3 previous surgeries in another center and 2 radiations. And she showed up in my clinic with a 6 1/3 partial nerve palsy on the left side with this tumor there, and still Cushing's disease, even after 3 surgeries and 2 radiations. And she's in her 30s. So young lady. So initially I debated about doing a peeling of the middle fossa, but I felt that it was all open and direct here. So I decided to go endonasal and see what I could do that, but I prepared this patient for a possible failure and the need for a craniotomy. So very important to drill. I remove all the bone in front of the cavernous sinus. As I opened and removed some of the scar, I got a CSF leak right away here. So I put a little gel foam there to prevent too much of a leakage of fluid. Now I'm exposing the carotid artery, expose the carotid artery. And here I'm removing the periosteal from that tissue underneath, try to define what is carotid artery, what is not, what is tumor bulging here. And Doppler was essential in this case. I Doppler here, I could hear the carotid here, but medial in this pokey area on the left side here, I didn't hear anything. Carotid was doing like a C of the siphon more laterally. And then I decided to come with a knife where there was silence on the Doppler, which was very medial, very carefully. I put a little incision there. I was very tense for this incision. You know, carotid is sitting right here. Then with the blunt ball probe, that's the technique I use. I've done many times this way. I put an incision, then I pop with the ball probe because that's not gonna hurt the carotid. And then after I pop with the ball probe, then I come with a dilator, basically a blunt pituitary cups. I put it in and then I spread. And when I spread, then you can see the adenoma that it's the source of her Cushing's disease there. And then I spread more, then I can even open that and send to pathology. And once I open that corridor, now you can see with the 45-degree endoscope, you can see the C of the carotid artery. And I basically went in the siphon. Deep there, you can see the lateral wall of the cavernous sinus, and then the soft tumor that was located inside. So very carefully, then I went with suction, and then I decompressed the cavernous sinus. Again, I don't say that I cured this patient, but we were able to get a completely purely cavernous sinus approach for a small tumor via endonasal. And we see the post-op, that tumor got decompressed. Her 3rd and 6th nerve got better in a couple of weeks. And the Cushing's disease is still a problem for her. The endocrinologists, they are taking care with Cranial and some other medications these days. You can see here the before surgery and the post surgery with the T2 now inside there. You know, very common we see on both sides, you know, not gonna go in much detail. I think the importance here is to really talk about the Doppler, the importance of using navigation as well, very helpful in these cases to go and decompress bilateral cavernous sinus. Sometimes you see tumors that progress into the 3rd ventricle all the way. If you look at this axial here, you see that this tumor entered the cavernous sinus and pop it through the wall of the cavernous sinus all the way to the 3rd ventricle there, sorry, the lateral ventricle on the middle fossa there. And by going into the tumor and following the tumor, again, you don't want to bring this upper part too early down. And you want to go here, go there, and then go up and resect this tumor. This is what you get. This patient is more than 10 years post-op with some residual in the cavernous sinus. As again, I don't say we can cure those, but very often they don't grow back. And this is an engineer, he's neurologically intact, and this is a non-functional adenoma, so he's recovered very well. We're just watching a little bit of residual around that carotid artery. The other concept that I think is very important to share is that it's not because it's a pituitary adenoma, you're gonna do always a endonasal or transsphenoidal surgery. This is a patient that had a recurrence of a large pituitary adenoma that had a process behind the clivus. So the surgeon did a transsphenoidal, beautifully remove all the supracellular component, but the patient recurred with this component down here. If you pay attention, this is behind the basilar artery. If I go here and I do a transclival to get this tumor out, I'm going to be fighting with the basilar in front of the tumor and possibly even perforators that way. So for this case, I just came with a retrosigmoid approach and removed this pituitary adenoma. It was very soft, so we actually was able to get a good view and aspirate everything, and got a patient is being in remission for many years with that resection. So again, it's not just because it's pituitary adenoma that you're going to do a transsphenoidal or endonasal in every case. So to finalize our presentation, I'm going to show some concepts that I think is going to be important in Pakistan, because as Dr. Salman was saying, the percentage of that you guys see a tumor like this is probably much higher. This patient actually came from another country to me, and you can see the size of the tumor with a very narrow area here. So it's impossible to remove this completely endonasal. And as you can see here, the projection anteriorly of this tumor was kind of poking through the brain. And if I go endonasal here, I need to go through the brain to then get into the tumor. And I thought that was not something that made sense with a very narrow area here. So cases like this, my current advice is to try to remove the whole tumor in the same anesthesia. Because if you go back and remove just this part, my theory is that you actually remove the drainage of the venous aspect of the irrigation of this tumor that was draining into the cavernous sinus, and you end up with a postoperative apoplexy. More than that, I came up with a concept that during surgery, you actually can see the tumor suffering apoplexy in front of you. So for the surgeons in the room, you will remember a case that very common actually for large ones, you start endonasal, you're in the cell and oh great, the tumor is soft. And as you go in the case, the tumor is very large. As you get to the upper part, the tumor is firm. And my theory is that actually this tumor is getting firm in front of you by venous congestion and forming like microhemorrhage inside. So it's basically mixing with a clot. And so these cases, if you could do endonasal in the same anesthesia, and that's craniotomy here. In this case, I tried to look at the cistern, and I actually had to cannulate with a port through the dome of that tumor. I left a little bit of disease around the anterior circulation, but a good decompression for the patient. And combining endonasal and a craniotomy in the same surgery, I think that's a very good alternative. I don't think waiting too much is an option. I'll show you this case to show the way I learned these things is with the error as well. This is a patient that had bitemporal hemianopsia with a tumor that was not very large, but had this component going to the right side, and the optic nerve was really pushed on this right side here, as you can see there. So I did a surgery endonasal. The patient woke up with a better vision after surgery. 10 hours after surgery, they called my team there because he was losing vision on the right side. My team overnight ended up doing an MRI, which I actually wasn't happy. They should have done only a head CT immersion. And they did an MRI that showed a venous bleeding, but the CT shows the whole story there. As you can see, it bled into the residual tumor. So I call this a postoperative apoplexy. And again, this happened just a few hours after. So I took the patient for a quick immersion craniotomy, and I removed the tumor. The nerve looked good at the end of the surgery, but this patient never recovered vision on the right side. He has normal vision on the left. So the way I do this case is particularly like this is an older person, and I'm always worried if I remove only this part of the tumor and I leave that other part, maybe I will cause a problem. Maybe that part will bleed. So what I've been doing now, I remove this as much as I can going endonasal, try to avoid a craniotomy for this patient. Anesthesia is ready to do a craniotomy, but I do an intraoperative MRI. And this is the intraoperative MRI. I take a look, I said, oh, you know what? I actually did a good job with the supracellular component. I don't think I need a craniotomy. You can wake up the patient. And that's the way I've been doing now. I plan for the craniotomy. I try to remove as much as I can endonasal. And then this is a few months later. You can see I left a little residue with that technique, but this patient now has been a couple of years out with a normalization of his vision, just a residual in the subarachnoid space that we are watching. The other advice that I give it to you is a case like this. This is a young kid with a TSH producing tumor. And you can see there is a spill of the tumor in the subarachnoid space. So for this is an example of a case that I do the flap from the beginning. And instead of going like I always did and opening the cella and removing the tumor on the cella and then dealing with this, like I showed in that old video, I actually started going straight through this to the upper part of the tumor, because I think that's still soft and you don't remove the drainage of venous drainage of this tumor, and it doesn't get engorged. So that's what I did here. I actually went to the second floor first, removed that, and then I went to the first floor and took the tumor out. This is the post-op. We put a flap here, and this patient is on remission of his TSH producing tumor with the preservation of this pituitary gland. So this is my advice if you're doing this endonasal and you want to try to avoid a craniotomy. Again, the goals of our surgery is to take a mass effect, normalize hypersecretion of tumor, preserve the gland, remove as much as possible, and collaborate with research with future for the future of our specialty, and send pathology for for analysis of the patient. So thank you so much, and I'd like to invite you guys as well. I don't think I have a slide here. This I do for spring of 2021. So exactly a year from now, we're going to have our courses restarting here at the Ohio State. And so because of COVID-19 this year, we're skipping, and we're scheduling for the end of April of 2021. Anyone interested, just send me a message. Those are all hands-on dissector, and we have a new lab now that simulates the operating room. So we're looking forward to that experience in the future. One thing, Salman, that we can talk about, actually, it's just came to my mind, what are we gonna do with these heads? I think there'll be a lot of heads out there with COVID-19. You know, are we gonna be in the lab drilling through and exposing all the participants or not? So I do think that as formalin and things like that helpful, but we still don't know much about this virus. I think this will be a concern in the future. I think the heads we have in our lab right now are all no problem, but for a year from now, we may need to test every head, before putting our team into that type of exposure. So thank you so much, and I'll be happy to take any question.
Thank you very much, Danny. It was wonderful. Danny, can you hear me?
Yeah, I can hear you well. Thanks so much.
So I think it was wonderful.
Look at the questions and, yeah.
Now, I've got a question for the benefit of the audience also. What's your incidence of empty cella syndrome? Because you're taking big adenomas out. And what is your strategy to reconstruct after the surgery to avoid empty cella syndrome?
You asking me or the participants?
I'm asking you for the benefit of the
sure. Yeah. So, it's very rare that we see vision problem with an empty cell. I think sometimes you see the MRI, you do see the optic nerves kind of flying low and then going back, but I never did any surgery to do any attempt of chiasmopexy that is well described. And it might be because also I've been putting all this material there to try to keep the gland up. So I think that's probably helping, because I've been doing that, I think, at least in the last 7-8 years, that I push all this material there to try to keep it up. And probably is part of the reason that I don't have a lot of those incidences. But I've seen in MRIs, that it's very scary how low the optic nerves dive into the cella before they go up. And I think as the pituitary stalk is dragged down with the gland, probably brings the chiasm down as well. So I like I said, I think the DI is probably related to that. And some people may have optic vision changes because of that. So I think putting structures, gel foam particularly, pushing that gland up will be helpful to avoid that type of complication. But I never took a patient to the operating room to try to release that. I don't know if you had to do that before.
Yeah, I think that's correct. Since we started packing the cella with the collagen matrix and gel foam, I think the incidence is reduced. But if you're taking the giant pituitary adenomas, because they're seeing a lot of giant pituitary adenomas in Pakistan. That's why I raised this question. If you're not packed properly, you can end up having the empty cellar syndrome later on. So my second question, again, for the benefit of the audience is, are you still using lumbar drains if you develop the leak post-operatively, not intraoperatively, you repaired it, and then a few days later, the patient develops the CSF leak? Will you consider lumbar drain, or you take them back to theater state?
Yeah, so first of all, we never use lumbar drain primarily during the first surgery. I try to do a repair the best possible, even if there's a big leakage, and then, but no lumbar drain. If the patient leaks, then I bring to the operating room, and that's a patient that not 100%, but I will consider putting a lumbar drain under anesthesia immediately after we repair. So we repair and I put a lumbar drain after, because you don't want to put a lumbar drain, get the CSF away, and then during surgery you don't find the leakage. So we do the leakage repair first, turn the patient under anesthesia, put a lumbar drain. In a good percentage of the cases, we will do that. But for the most part, we try to just repair. If it's a small leak repair, I may just repair and not put any lumbar drain afterwards. And usually, if I use a lumbar drain, I keep it for 5 days. I usually drain around 15 cc's per hour, no more than 20 for sure. 10 to 20 cc's per hour is what we drain. Some people have a headache. We have a new actual device here now that calculates the flow. So you put that in the machine, and it constant flow that out of the patient, and the patient actually stand up and move around safely. I have no interest with that company, but it's called the Liquor Guard. It's very, very smart. I think it's safer for our patients to use that if you want to take a look.
No, that's good. So you're not using it as a primary treatment. You might use it as adjunct.
Correct. I will never just put a lumbar drain in the post-op because it's leaking. I prefer to take patient to the operating room and then consider there.
That's good. The last question from me is, again, for the benefit of the audience. Do you have any experience, any case of aseptic meningitis after the pituitary surgery?
I do, but not really with the pituitary adenomas that I remember right now.
Meningiomas.
But no, more I was thinking with the cystic lesions. I had it before with large reticleft cyst. I had it with dermoid tumor. I had with, I think, craniopharyngioma as well. I think the cyst irritates and causes more like a chemical meningitis. I think some of these that we think is chemical for meningiomas and maybe an adenoma, it might be really bacterial. And sometimes you don't find the bug because of antibiotics already started, that type of situation. I did have in my career 2 cases of pituitary adenomas that did not have any leakage and end up with a meningitis bacterial afterwards, even without a leakage. Both were very large, and we actually had to use a flap for reconstruction, and they end up with a leakage during surgery, but not afterwards, and they end up with a meningitis. So I think we have to be very vigilant for those, and any question after surgery, even if there's no leakage, the way I discovered one of them is because I did a head CT and the ventricles are a little more dilated. And I said, well, there's something wrong. There's no leak, but ventricles dilated. So I actually asked my team to do a lumbar puncture. Patient was still in the hospital in the first week, and they called me because it was milky. It was probably a contamination during surgery. So we have to be careful with those as well. And then antibiotic, and he did great eventually. So
that's good. I had a case of acromegaly who deteriorated after surgery, and then we did lumbar puncture because we didn't have a CSF leak. We didn't see anything on the scan apart from early dilatation of the ventricle. And it turned out to be aseptic meningitis, probably from the packing material.
Right.
Had a very stormy course for a few weeks.
Right. But did you use antibiotics just in case?
I did.
Yeah.
Although I didn't find any bug on it.
Right. I think we see some of those, and I think some of them is actually we call chemical, but there's a good chance that it's contamination and meningitis from bacteria. Then that becomes kind of subclinical there with more protein elevation. but there's a potential for some like a low level of bacterial meningitis on those.
Are you using any diving technique for the microadenomas?
I do sometimes. You know, we learn from Dr. Locatelli, and we do. I think is helpful in some situations. You basically let the flow of irrigation come out, and you dive into it. It's helpful when there's no blood. If there's a little bit of blood, then you don't see much. It's something I use if I feel a need. I don't do routinely like Dr. Locatelli does, only if I feel that is necessary.
So Salman, there are a couple of questions from the audience. You want to ask those? Or
the typical question that every endoscopic surgeon gets: what do you do with carotid injuries if you get one?
Oh yeah, that's a good question. You know, thank God I don't have a carotid injury in a pituitary surgery, so that's why I don't have in this talk here.
Good.
I have 3 in my career though. I have 2 in chordoma, and 1 I was doing a meningioma that I got that. So that's probably another whole talk, you know, about what to do. But I think in few words, what I can say is that you got to get out of the operating room, keeping the patient alive. So you want to identify the hole. You want to use preference muscle to control that bleeding. Of course, you'll be situations where the carotid is dismantled or cut it across, and there just muscle is not going to help. But if you have a small hole, then muscle that you have to elevate it. Usually we prep the quadriceps, and then you take muscle from the quadriceps because it's a big muscle and fast, and the patient's not going to miss a piece of quadriceps. Then you have to like you know, disrupt some of the fibers, and then you put it there. Then you send to the patient to an angio, and an angio will have 3 options. Either your angio partner, endovascular partner, will be able to reconstruct with a stent, or will not be able to do any reconstruction and will need to sacrifice the carotid artery using coils or any other balloon. And the third option is that you do an angio, and the angio is perfect without any pseudoaneurysm. If there is a pseudoaneurysm, you have to do something. So I actually, my 3 carotids of my career, we have 1 flavor of each. So 1 was a chordoma, we had to sacrifice the carotid. There was nothing they could do. They could not pass the stent. It fell apart because previous radiations and multiple surgeries. She did well with that sacrification of the carotid, no stroke. The other case that we did, I was drilling the carotid on another chordoma, and I got a small perforation. Angiograms showed a pseudoaneurysm. So because of the pseudoaneurysm, our decision was to put a stent. And so we had muscle through the nose, a stent through the carotid. And that carotid we actually able to save. We saved that carotid. That patient had normal perfusion, but I had a complication on that patient. She was 78, and she, because of the Plavix for the use of the pipeline, they described 2% of a remote bleed, and she actually had a contralateral remote bleed near the cortical motor area. So she ended up with hemiparesis on the contralateral side. So it's kind of crazy, but we preserved the carotid by using the muscle and the stent. And the third option is the one that we actually did an angio, and there was nothing abnormal. So we basically kept the patient in the hospital for a couple of weeks. We did multiple angiograms and all normal until we were able to send her home. And that was during the approach. So 3-4 months later, I had to take her back to the operating room, did a craniotomy, get the tumor out via craniotomy. I didn't want to go through the same pathway again. And she's more than a year out, and she is fine. We did CTAs, and we did a lot of angiograms, and basically her gland, her carotid artery recovered just by using muscle and no pseudoaneurysm formation. So it's still possible to preserve the vessel, but you got to be vigilant. Any formation of pseudoaneurysm, in my opinion, you have at least to reconstruct, try to reconstruct with a stent.
And your indications for craniotomy or supraorbital craniotomy?
For pituitary adenomas, you mean?
Yeah.
I think I probably brought it up a little bit. I tried for the most part to avoid a craniotomy in these cases. I tried to remove everything endonasal.
Yeah.
But if I see that the tumor is spilling into the subarachnoid space beyond the gland, if I see irregularity, the tumor is not very round, it has Mickey Mouse ears around. So those usually to me shows that it has spilled into the subarachnoid space. And that's when I'm ready for an eyebrow or craniotomy combined with the endonasal and the same anesthesia. And I do an intraoperative MRI to see if I remove everything, like I showed the example during the presentation. But I very rarely will start with a craniotomy in these cases.
Okay, Gibran is asking about, is there a way for a newcomer, a new person who's operating, a trainee, to differentiate? What's the way to differentiate between tumor and the gland? Because many times they think that, you know, in the microscope or endoscope, they can hardly see any differentiation.
Yeah,
so do you have any tips for that?
Yeah, I think I mentioned during my presentation, the color can be difficult, but the blood supply in the gland, you can still see some little vessels because it has its normal architecture. So you can see vessels on the gland, and usually the tumor is more chaotic of architecture disruption. So usually you don't see those vessels. It's either pale or you know, this, like you don't see any normal architecture of vessels on top of it. So that's one of the things. That you know, an experience, unfortunately, you know, like it's hard to
see videos.
Yeah, that's right.
Okay, so last question before we go on to Amjad is, if you're in the cavernous sinus, how do you prevent or preserve nerve palsy in there?
Good question. I didn't mention, and usually I mention that, but every time I'm gonna go into the cavernous sinus, I do cranial nerve monitoring. I used to monitor 3, 4, and 6 for the side I'm entering, and I always do then somatosensorial vocal potentials on these cases. But more recently, I stopped monitoring 4. I just monitor 3 and 6. And in some cases, I only monitor 6. I usually see if there is any contact with the cranial nerve 3 in the upper part, then I do 3 and 6. And 4, I don't do anymore. Small nerve and small muscle. I think it's just one more needle on the eye of the patient. And so I only monitor 3 and 6 for the most part now. And you need a good team, so they need to know how to really apply those needles, because you need to trust them. Like one risk is false negative, right? So you may be touching the nerve, but the needle here is on the skin, and then you're not going to get any response. So you need a good team. They need to look at the amplitude and the rest potential that you see. The presence of the needle is located in the muscle there. So you need a good team for that.
Okay, just the last question again from a junior is, do you put the bone back in small or big tumors?
No, for pituitary adenomas, I do not. So if I use a flap or a graft, I don't put that bone back. The bone in the sinonasal cavity, it tends to increase the risk for infection as well. I think we had a few cases in my career where that bone that you put in front of the sella fouls and stays on the sphenoid and becomes like a malodorous and cause inflammation of the mucosa. So I prefer to keep it clean. I take that out, and I either will put a graft or just put a flap in those cases that requires a flap. Okay,
thank you, Danny. That was wonderful. There are loads of questions, but I don't think we'll be able to take all of them. Amjad, would you like to screen share? And we're going to do this and then do the MCQs at the end.
Okay. So this is a section just for the trainees. You have heard a wonderful talk from the Danny, how to operate. So I want to share a few cases with you where probably surgery is not the primary treatment. So you need to remember these cases. So can you see the screen? Yeah?
Yeah.
So So 33-year-old female with severe headache and weight loss, hyperprolactinemia, hypoadrenalism, hypothyroidism. And MRI, which I'll show you in a minute, which shows intrinsically T1 bright and T2 intermediate signal lesion in the left posterior cell. So have anybody heard of pituitary cytoma?
Yeah.
And where does it rise?
Should I answer or just let it people?
See, any juniors have any ideas?
Okay, Adnan Khalik says posterior pituitary.
Yeah. What are the other tumors which arise from the posterior pituitary?
Okay, other tumors from posterior pituitary. So the answer is coming as granular cell tumor.
That's right, which is called choriostoma. So how does the pituitary cytoma differs from the pituitary adenoma in terms of treatment?
Amjad, sorry, if you could put this on full screen, please. Just slide share. Go on to the slideshow, go above. Yeah, there is slideshow on the top. Thank you.
Oh, that's taken me to the start of it now.
So just you can go forward, it's fine. Oops. Where do you need to go? Is it nearby or?
Okay, that's the one.
I think you had a case 3 before.
Yeah, that's it, case 3. So that's the one. So how do they differ from the pituitary adenomas? How does the management differs? Danny, have you any experience of these?
Yeah, actually, I have a publication coming out of this. I have a couple patients only. Then my friend from Argentina had a couple there, so we actually put it together and we did a review of the literature. Because my experience, if you go back on your picture of the MRI, my experience is not great. Like they are very bloody, and if you go back.
Sorry, go back. If you bring the cursor down.
The problem also, you have the pituitary stalk. See, you can see there, the gland is normal. So this is really like, I approach it the same way I approach a craniopharyngioma or a meningioma in the supracellular space through a transtuberculum transplantum approach. And I've done that a couple of times. I only have, I have one patient that is exactly like what you're showing right here. The other one I had, it was a little smaller. But what I did, I noticed that the surrounding of the tumor was basically the pituitary stalk dilated. So I performed an incision and I debulked the center. It was very, very bloody, very, very bloody, and was kind of firm as well.
And they're very
vascular. Yeah, so I end up like removing the internal 2/3 of the tumor. I decided not to go around because I felt that I would probably cause problems. The patient had normal pituitary gland function. And that's why I wrote this paper recently now, because when I look at that, I felt like I'm gonna just watch it before giving radiation. And a lot of the literature says to give radiation. So when I did this meta-analysis now that we're gonna publish soon, we came to a conclusion that there's no evidence that radiation is actually good for you for this. Yeah, so I actually just watched it. This patient has been 4 or 5 years that I watch it and 0 growth. And he is neurologically intact, vision got better, and his gland, he has at least some function. And so that's what I did on this more recent case. I also got a partial resection or subtotal, and I decided to just observe, and they barely grow afterwards. So, yeah,
that's the message I want to give to the trainees. They now experience, they barely grow. If they don't have any visual disturbance, you can leave them alone and watch, but you can see the normal pituitary is separate from it. So I know.
Yeah, I agree 100%. Good case. Thanks for showing that. I should include that in the future in my talk.
Okay. So I will now go on the retrospective. They were reading all that. So again, this 52-year-old patient presented with headache, vomiting, and altered sensorium, and endocrine dysfunction and hemodynamic instability. So that's the history, and that's the scan. So my question to you people is, how do you differentiate it from the Rathke's cleft cyst, and what would you do with this patient, and why patient is hemodynamically unstable?
Okay,
Any
anybody
junior
wants
can
to,
take that?
yeah, anybody who wants to answer, just raise their hands and we'll switch on their mic. Can you ask that question again, Amjad, please?
So question is that from the history, why you think it's pituitary apoplexy? Why, how would you differentiate it from the Rathke's cleft cyst, looking at the scan? And why you think patient is hemodynamically unstable?
Any takers?
So you can see the. So you can see the.
Okay, it's Malappa Huji. His mic is on. Yes, please
Yeah.
go on. We can hear you.
We can do a diffusion weighted imaging to see whether to differentiate between apoplexy and Rathke's cleft cyst. And the patient is in crisis because of hypocortisolism, which is secondary to apoplexy.
Very good. And what would you do with this patient? How would you manage it?
I would do a complete hormonal profile and would initially give him cortisol, and if possible get a visual perimetry done, and within 24 to 48 hours we have to do a transpenoidal surgery.
So patient vision is stable, patient is hemodynamically unstable. So you've done the endocrine assessment, you have stabilized the patient. Now patient remain visual stable. So why would you operate on the patient? So we did the endocrine review, endocrine management, and because patient vision was stable, cortisol brought his blood pressure back. We just waited, and in 3 months' time, without surgery, resolved. So Danny, message for the trainees is, when will you operate on a patient with the pituitary apoplexy, with worsening vision or any other reason?
No, I think vision, interestingly, double vision, if you have a tumor that has an apoplexy and causing double vision, those are most likely to recover as well. Yeah. I have a tendency to see if the patient is young, then I rather do surgery. If there's any deficit, I take actually these patients to surgery. But I not too long ago, I had an 81-year-old gentleman that showed up with a ptosis and a partial third nerve palsy and an apoplexy. And the tumor was not going into the suprasellar. So vision was not, optic nerves were not in question. I actually decided not to do surgery. I observed only. And a few months later, he came back and his vision was, double vision was gone. He was normal.
And even third nerve recovered.
And the tumor recovered, yeah.
Yeah.
I have another interesting story in my practice. When I was in Pittsburgh, I was a young attending, and I scheduled surgery of a tumor that was similar to the one you just showed. And I scheduled surgery, and things happen very fast. The night before, I did an MRI to put it in the neuronavigation system, but I didn't pay attention. I just did that MRI. And then we put the patient under anesthesia. The anesthesiologist intubated, and then my fellow, or one of the residents, looked like, Dr. Prevedello, where's the tumor? I don't see the tumor. I don't see the tumor here. And then I look at the MRI from the day before, and it was completely gone because the original MRI was like 2 months before, and it was quite large cyst, and it was gone. I told the anesthesia to wake up the patient. And
I'm publishing my series of 88 cases now. Only 2 I ended up having surgery. 86. Yeah, 86 didn't require operation. So that's the message for the trainees. This is the second pathology. Don't rush for surgery as long as there's no need.
But I just want to say one thing about that. You have to be careful observing, watching this patient again for years, because they may grow back. Not necessarily the entire tumor is dead. So they may grow back and they may bleed again. So that's, you have to be careful on the follow-up.
So another case, 35-year-old female presented with galactorrhea, amenorrhea, and raised prolactin level and raised thyroid stimulating hormone. And this is the scan, uniformly enhancing lesion. Anybody can take this on? Tell me what it is and what would you do?
Okay.
35,
okay.
raised TCH, hypothyroidism, young female.
It's a good case.
Who's gonna get the knife out?
There's not a single neurosurgeon that is gonna face a few of these
Again,
in their career.
it's again Dr. Malappu.
Okay, Malappu.
Hello, sir. I feel it's a.
Please just tell us where are you from, and then.
I'm from a place called Hyderabad in India, sir.
Okay.
Hyderabad in India. Yeah. So I think it's a thyrotropin secreting hormone. The raised prolactin could be because of adenoma, which suppresses the HPA axis. And the hypothyroidism itself is causing amenorrhea in this lady. So we should go ahead and do a transpterygoid excision.
Okay. So anybody else?
Can I say what I would do there?
Yes.
I would treat the hypothyroidism first.
Well done. So because it's completely uniformly diffusely enhancing lesion, young female hypothyroidism, this is a case of a pituitary hyperplasia, and we gave her, just as Danny suggested, replace the hormone, and that's what happened to the tumor. So please, all the juniors, remember this condition, keep your knife in your pockets. And that's why I gave you the hint, all the cases I'm presenting are the one which may not be surgical. So this was a pituitary hyperplasia, young females with long-standing end organ failure or hypothyroidism is the key feature in this. All you have to do is, if you see how diffusely, uniformly enhancing the lesion is, bright pituitary. So you don't need to operate on these patients. Okay, I'll go to the next now.
Okay, let's quickly do that, Amjad, because we are running short of time. Sorry.
Or I can stop here if you want.
No, we can quickly do this one as well.
The 33-year-old female with severe headache. This is, I think we've already done.
Yeah, this we did.
This we done. So I'll show you one more. So any take what it is. This patient was referred to me as a microadenoma, incidental finding, spot diagnosis. So it's a Rathke's cleft cyst, any low density right at the bottom of the stalk, midline is Rathke's cleft cyst. So you don't have to do anything. You don't have to follow them up. You don't need any surgery on these cases. So it's a Rathke's cleft cyst. Remember this. And this is also important. 24-year-old female with intermittent headache for 6 months, 1 month history of amenorrhea, 2-week history of polyuria, polydysplasia, and it presented in first week postpartum. So has anybody any experience of pituitary abscess?
Yeah.
Danny, have you had any evidence, any experience of pituitary abscess?
So for these is I questioned that. So if you do surgery, you go there and it looks like pus inside, and you can call pituitary.
But you never grow anything.
Yeah, it never grows anything. It's usually aseptic, and the differential diagnosis, which is very difficult, is actually a hypophysitis of the pregnancy with necrosis. And I still, up to these days, is confusing for me, all these cases, because sometimes if you culture, sometimes you have some growth, but it's contamination of the nose because you're going through the nose. So it's I think this forms a group of pathology that I put it together, which is pituitary abscess,
hypophysitis.
And hypophysitis, exactly. So particularly related to pregnancy, it could be pituitary hypophysitis.
So what we started doing now is we don't rush do anything on this patient. We replace the hormones. Sometimes we give them course of antibiotics, and most of the time it gets better. So that's again.
Yeah, I agree. And sometimes you can do a pulse of steroids and also responds very well.
Yeah. Okay, I think Amjad, thank you very much. Those cases were brilliant. I think it just tells you that not everything needs to be done with a knife. I think Denny, would you share? I think Imad, are you sharing the forms? Okay, so 115 people have responded. Okay, Danny, you want to take them, please?
Yeah, I'll read it here. So it is important to identify the pituitary gland. The idea is like better not to see the pituitary gland in these cases. It's better to just see at the end of the procedure against the diaphragma celli or immediately after opening the cellar dura, since there's a little bit of typos there, or in the side of the invades the cavernous sinus. So where and when is the important to identify the pituitary gland based on our presentation? Okay. Should I say the answer or give us some time?
No, because
I will look later.
Yeah, we will show the answers afterwards. So
perfect. So question number 2 is how often you will see CSF exposure intraoperative for pituitary surgery? Is it 1%, 2.2%, around 5%, or around 15% of the time we will see intraoperative leakage?
Okay.
The other question is like, how much should you tell the CSF leak chances for the patient afterwards? What is the chance you're going to need to take the patient back to the operating room because of CSF leak? Is it never, 2.2%, 30%, or 10%? Is A, B, or C, or D? Cellular reconstruction can be performed with collagen matrix, fat graft, flap, or all of the above.
Okay.
And last question, is important to keep the diaphragma celli with the pituitary gland pushed up at the end of the procedure to avoid what? We talk about that and even discuss, so this should be easy. To avoid the CSF leak, A, B, to avoid diabetes insipidus, C, to avoid the empty sella syndrome, D, long-term vision deterioration, or all of the above.
Okay, let's look at the answers now.
Let's go to number 1. So beautiful. Most people here, more than 2/3 of our audience got it right. Immediately after opening the cellar dura, you want to look for the pituitary gland, and that's exactly like I pointed up on the presentation. You know, the technique of not to see it, and I disagree, which is A, you want to see what you fear. I learned that from Amin Kassam. Everything you fear during surgery, you should see, because then you can protect it. And sometimes almost 20% responded that at the end of the procedure diaphragm. It's end up what you see most commonly, but what I tried to show you here today is that trying to find that gland earlier when you open the cella is in your best interest to preserve function. And you will never find gland on the side is invading the cavernous sinus. Usually the gland is going to be on the opposite side if it's asymmetric. So let's look at number 2. Congratulations, most people got right. Number 2, how often the CSF is exposed? In my practice, I said 15% during the talk. So that's 27% people got it right. I think this can be confused. People that wrote C, around 5%. That can be more or less what you can get post-op. But intraoperative, if you're doing good resection, it's going to actually, in the book, says all the way up to 30%. In my own practice here, it's around 15% of the time you get a leak during surgery. It doesn't mean you're going to have a leak after surgery, which is the next question.
Okay, number 3.
3 is exactly that. So how often we will see a leak after surgery? So I showed these numbers in my presentation. Who paid attention got it right. Almost 70% answer correct. I have 2.2% in my series. And of course, it's not wrong to see 10%. You know, I've seen people's practice that 1 in 10 will have a leak. I actually, my own series, when I talk about meningiomas that I go through the nose, that will be a correct answer. Around 10% will have a leak after surgery because it's more of an invasive and opening and removal of the dura. But congratulations, most people got it right there. Around 2-3% is the correct answer for most series published in the literature as well. Number 4. So the cellular reconstruction can be performed, of course, with all of the above. Sometimes we only use collagen matrix. Sometimes we use fat, but I like I mentioned in my talk, I don't like to use fat because it causes artifact in the MRI post-op, and I prefer not to use it. And somebody asked that in the questions as well that I saw it. And the flap rarely on the cases that we go to the subarachnoid space or we got a very large leak. And the reality, we combine all them, 90% got it right. And the last question is why is it important to keep the diaphragm pushed up? And I think here it's all of the above as well. It's all related to avoid that empty cellar syndrome that can be causing late deterioration of vision, can cause diabetes insipidus based on our experience. And by putting the contra pressure on the diaphragm macella, also you prevent the leakage of fluid by performing that technique. So more than half of the people got it right, 57.7%. Congratulations, everybody.
Okay, brilliant. This is, as we expected, more than 80% excellent and 15% good. That's what we thought. The quality of evidence go down further. And again, more than 80, it's altogether 99% of people said good and excellent. Overall, I think you missed that overall. Yeah. So again, same 99, in fact, 100% good and excellent. And I think only Amjad didn't want to hear you again. Everybody else wants to hear you again. So that's one person who's saying it doesn't want to hear you again. Listen, Danny and Amjad, I think you both did excellent talks. It was really, mouth-watering talks that we had. Those cases were really good for residents. And Danny, the way you showed the junior residents how to go about things was wonderful. And yeah, I'm grateful for
show the details and that it really focused on the minutiae of the technique. But I think for the future, Amjad, I think I'm gonna do is to add some cases that we didn't do any surgery. I like that you emphasized that. I think it brought a good equilibrium to my more surgically aggressive presentation.
No, okay, I think it's good for the beginners.
I agree.
For Wednesday, we have Walter Jean from George Washington University talking about approaches of skull-based tumors, and Azam is going to be moderating that session from Wisconsin. Imad, do you have another presentation for after that? Yeah. Our friend John Lee is going to be talking about endoscopic CP angle tumors, and Yoko Morotel from Hamburg, not Hamburg, will be with us in that, and we're going to have interesting sessions. So thank you, everybody. It was really our pleasure. It's actually our future talks which are shown here, and we are with Amjad and Azam. So John Lee to follow, followed by again we have a Roton anatomy session that we are starting this Saturday for residents. So Azam and Chandrasekhar Dev Pujari are going through that. Then we have simple disc prolapse with Greg Trost and Doug Orr. Salim Abdurrauf is going to be talking about anatomy of skull base on Monday week, so next Monday. And then Luis Baba is going to be talking about craniopharyngiomas. Giovanni and Richard Asakar have hybrid surgery and thoracic disc. And then we're going to have another IFNE and WFS endoscopy update on Saturday week. We have Liliana Angelov from Cleveland Clinic and Greg Trost from Wisconsin talking about the tumors in the spine. And we have Rick Fessler to follow that with Olaf. And hopefully we can persuade Danny to give another one of his interesting talks to us in the middle of all this.
Yeah, it'll be my pleasure when you turn in there to the next round and let me know. I'll be happy to come back.
Yeah, we'd love to have you back. It was brilliant. And thank you, Amjad. You were brilliant with your cases and excellent for the residents.
Thanks.
Good to see you. Good to see you all. Thank you so much.
Well done, Salman. Well done.
All right, take care of yourself and be safe. So we'll see you soon.